If you're an EMS, you've been on this call, a behavioral health crisis. And almost every time, the default destination is the ER. But is that always the right call? Is that the best place for every single one of these patients? Today, we're going to dig into a guideline that offers a totally new path, a more direct route to the right kind of care. Okay, let's just start with this. This quote, right from the source material, gets straight to the heart of the issue. It really challenges one of the most basic field assessments we use every single day, and it totally sets the stage for a much deeper look at patient capacity, which, as you'll see, is the absolute cornerstone of this whole thing. All right, so here's our game plan for this explainer. We'll kick things off by introducing this new path for care. Then we'll dive deep into what it really means to assess patient capacity. From there, we'll tackle the supercritical protocols for suicidal patients, lay out the warm handoff process, and finally wrap up by looking at the huge impact of getting this right. So let's get into it. The solution we're looking at is a protocol called the Treat and Refer Guideline. I want you to think of this as a brand new tool for your toolkit, one that's specifically designed to get patients connected to the best resources for them, which often aren't inside a hospital. So what is it exactly? Well, this protocol is built for patients who are actively asking for help. Things like substance withdrawal or suicidal thoughts, but, and this is the key, they haven't made an active attempt. This guideline gives EMS providers the power to connect these patients directly with community resources and specialized care, completely bypassing a trip to an already crowded ER. All right, now for the first and honestly the most fundamental step. Before you can even think about using this pathway, you have to figure out if the patient truly has the capacity to make an informed decision. And as that first quote made clear, this goes way, way beyond just being alert and oriented. Just look at the contrast here. We all know ANO times 4. We live and breathe it. Person, place, time, event. But true capacity, that's a whole other level. The patient has to show you they get the risks and benefits. They have to actually understand the care you're offering. And most importantly, they have to be able to make that call without their judgment being impaired. It's not about orientation, it's about real comprehension. So let's talk about where the rubber really meets the road with this guideline. Calls involving suicidal patients. This is where the decision-making is just absolutely critical, and patient safety is without a doubt the #1 priority. The whole thing, the entire decision tree, it all boils down to this one single question. Has the patient made an active suicide attempt, or are they dealing with suicidal thoughts, just the ideation, alone? Your answer right here determines everything that happens next. And this lays it out perfectly. There are two very different paths. If there's been an active attempt, an overdose, self-harm, anything, or even if a reliable person on scene thinks there has been, the decision is made. That patient must go to the ED. No exceptions, period. But if it's ideation only, with no active plan, no attempt, then that treat and refer door opens up and you can get the crisis team involved. And this right here, this is the number that makes it all possible. This is your direct line to the Arizona Crisis Intervention Services. They're a specialized team trained to evaluate these patients right over the phone and help you figure out the safest, most appropriate next step. Okay, let's be crystal clear about this. Patient safety is completely non-negotiable. This whole protocol is built on these absolute rules. You never, ever leave a suicidal patient alone. There has to be a responsible adult there, and if there isn't, you wait with them. And remember, the ultimate safety net is your gut, your clinical judgment. When in doubt, you transport. Simple as that. So you've decided the patient is a candidate for this pathway. You've made the call. What's next? It's something called a warm handoff. Now, this isn't just a quick sign-off. It's a structured conversation to make sure nothing gets missed and that the patient gets truly seamless care. And here's a little pro tip straight from the guideline. The second you get someone on that crisis line, the first words out of your mouth should be, "This is a 911 EMS provider." That simple phrase is like a keyword that gets you routed to the right people right away. The handoff itself is a really clear 4-step process. You've already identified yourself as EMS. Then you give the patient's basic info. You give a quick, concise history of what's going on. And then, and this is so important, you explicitly tell the crisis team that you have already done a capacity evaluation. So after you've done the handoff, a few things could happen. The crisis team might be able to handle it all over the phone and you can clear the scene. Or they might be sending their own transport. If there's a responsible adult there, you might be able to leave the patient with them to wait. And if not, like we said, you stay put until that transport arrives. Okay, so we've covered the what and the how, but let's finish up by talking about the why. Why is a guideline like this so important?
It's all about a massive shift toward what we call right-sizing care.
This quote right here really captures the level of professional responsibility we're talking about. When you use this protocol, you're not just dodging a transport, you are making a clinical assessment. You are saying this patient is medically stable and a specialized behavioral health facility is a better, more appropriate destination than a busy ER. And the benefits here are just huge for everyone. For the patient, it's a game changer. They get connected directly to the specialists they need, way faster. For the healthcare system, it's a relief valve for overcrowded emergency departments. And for us, as providers, it gives us a really powerful and meaningful way to provide better, truly patient-centered care.
A guideline like this is such an amazing step forward, but it also leaves us with a bigger question to think about. As our role in pre-hospital care keeps getting bigger, moving beyond just emergency transport, what other tools and what other training do we need to really bridge that gap between a 911 call and the overall health of our communities?